When performing a hand exam, it is important to be thorough and systematic in your approach. First, elicit a thorough history and mechanism of injury to guide your exam. It is important to determine the position of the hand at the time of injury. Grossly inspect the hand, both dorsal and volar aspects, scanning for gross deformities, swelling, or discoloration, making note of any apparent wounds. All foreign bodies, such as rings, should be identified and removed. Palpate the hand thoroughly, noting areas of tenderness, crepitus, or temperature differences that may indicate underlying vascular compromise. A quick check of each finger's cap refill is also important. Have the patient close their hand and ensure that the digits appropriately angled towards the scaphoid as noted here. Upon extension of the hand, visualize the PIPs for alignment or rotation irregularities. The passive cascade exam is next. Wrist extension should elicit digital adduction and flexion. Wrist flexion should elicit digital abduction and extension. The mnemonic dab and pad reminds us that when you dab your fingers downward, the dorsal interossei abduct the fingers. And when we look at the palmar pad, the palmar interossei adduct the fingers. The sensory exam evaluates the radial, median, and ulnar nerves. General landmarks should focus dorsally on an imaginary line that bisects the fourth digit sagittally and the second through fourth PIP joints transversely. On the palmar side, again imagine a line bisecting the fourth digit as well as one bisecting the thumb. Pure sensation can generally be isolated to the following areas for radial, median, and ulnar nerves. The motor exam can be done quickly and systematically. First, evaluate the median nerve. Have the patient oppose the thumb, which confirms thenar muscle function. Then have them abduct the thumb against resistance and palpate the thenar muscle belly to ensure contraction. Have the patient give the OK sign, testing against resistance, testing the anterior interosseous branch of the median nerve. Digital adduction, test the strength of the palmar interossei. Abduction, test the strength of the dorsal interossei, and segues your exam to the evaluation of the ulnar nerve. Further ulnar nerve motor testing should focus on the thumb. Thumb adduction is evaluated by having the patient hold a piece of paper. This exam is then confirmed by having them hold the paper with a pincer grasp. If they are unable to adequately perform this, the adductor is weak, indicating a possible occult ulnar motor denervation, and result in the patient utilizing the flexor pollicis longus, resulting in a pinch that looks like this, a defect that is called Froment's sign. Lastly, the radial nerve is easily deemed intact with adequate extension of the fingers and wrist. When evaluating the tendons, it is important to evaluate range of motion against resistance. A tendon with up to 90% laceration can still exert normal strength and range of motion when examined without resistance, leading to missed injuries. For the flexor digitorum profundi, hold the PIP joints of the finger to be tested and ask the patient to flex their digit against resistance, evaluating only the DIP. For the flexor digitorum superficiali, have the patient flex their finger holding the MCP, this time isolating the PIP function. The extensor digiti minimi is assessed by laying the hand on flat and having the patient elevate the fifth finger. For digits 2 through 5, the same maneuver is applied and can be done individually if the mechanism necessitates it to evaluate the other extensor digitory. The extensor pollici should both be palpated during extension of the thumb. The ulnar collateral ligament can be evaluated by applying lateral stress to the MCP joint of the extended thumb. Normal laxity is approximately 15 degrees, with anything more than approximately 35 degrees is concerning for a partial tear.